Welcome, everyone, to Ink and Air from optimalanesthesia.com. Just a quick note, our full evidence-based content and scripts, well, they'll be available starting June 2025.
That's right.
Today, we're really diving deep into something pretty intense, managing a severe crush injury. Imagine this. A patient comes in, limb crushed, time ticking, and there's this huge risk of hyperkalemia, that dangerously high potassium.
Exactly. It's life-threatening stuff. We're going to unpack a real case, really get into the physiology, the decisions, the why behind it all.
Okay, so set the scene for us. What are we dealing with here?
All right, so we have a 49-year-old male. He's got a degloving crush injury to his right arm. And here's the first kicker. The injury is already over 7 hours old by the time he gets to us.
7 hours? Wow, okay.
Yeah. He's 90 kilos,
Yeah.
no known major health issues, no meds, no previous surgeries that we know of. But the airway assessment, that flagged a potential issue. Thick, short neck, Malapati grade 3. So maybe a tricky intubation.
Gotcha. And his vitals when he hit the OR.
Heart rate was 81, blood pressure was low, 91/56, saturation 95%. But critically, and this is huge, no initial lab work was available yet, 0 baseline.
No labs, potentially difficult airway, low BP. Had a tough starting point. What was the surgical plan?
Plan was external fixation and debridement. Needed to clean up that damaged tissue. Apparently, a relative had refused amputation earlier, so the pressure was definitely on. Urgent situation.
Absolutely. So the mission for us today, for this deep dive, is to walk through the anesthesia management step by step.
Precisely. We want to dissect the critical thinking, the physiology driving the problems, and the rationale behind every single intervention. It's about understanding why they did what they did in this specific, very challenging scenario.
Okay, so patient arrives in the OR, no labs, tricky airway flagged. What's the immediate thinking process for the anesthesia team, pre-induction concerns?
Well, top of the list has to be preload. You're immediately suspicious of low preload, right? With a crush injury that severe, especially after hours, you expect significant fluid to have shifted out of the blood vessels into the injured tissues. Third spacing.
Right, so the tank is likely low, essentially.
Exactly. So even though you don't have a ventilator hooked up yet to get a positive pressure variation or PPV reading, you're already assuming this patient is probably fluid responsive, needs volume.
Makes sense. How did they start the anesthetic then, given all these unknowns?
Okay, so pre-medication was glycopyrrolate 0.2 milligram IV, probably to help manage secretions, anticipate airway manipulation.
Standard stuff.
Yeah. Then for induction, they used midazolam 2 milligrams and fentanyl 200 micrograms. And then here's the big one. Choline 120 milligrams for rapid sequence induction.
Whoa, okay. 6-amylcholine with a crush injury over 7 hours old. Even without labs, that sounds risky, given the hyperkalemia potential.
It's definitely a major decision point. And you're right to flag it. The explicit rationale given was no available labs and the perceived urgency of the situation. Severe injury, hours old, potentially full stomach. They needed to secure that airway fast to prevent aspiration.
So the immediate airway risk outweighed the theoretical unconfirmed potassium risk at that exact moment.
That seems to be the thinking, yes. A calculated risk made under extreme pressure. It highlights that difficult balance we sometimes face. We know succinylcholine can cause potassium release, especially with muscle damage due to those extrajunctional receptors proliferating.
Right, like Merrick and Martin described.
Exactly. But without knowing the starting K+ win and needing that rapid onset for RSI, they chose succinylcholine.
Okay, so how did the intubation go?
They used direct laryngoscopy, applied the BURP maneuver, backward, upward, rightward pressure, and successfully placed an 8.0 millimeter endotracheal tube.
Good, airway secured.
Yep. Then they started inhalational anesthesia with sevoflurane in air and oxygen. And they quickly moved to get better monitoring in place, put in a right internal jugular central line under ultrasound. But importantly, no arterial line yet at the point of induction.
Right, so continuous BP monitoring wasn't available right at the start. Let's step back, the molecular level stuff. How does the crush injury itself cause these systemic problems like the fluid shift?
Well, the trauma just wrecks the capillaries locally. They start leaking fluid, protein, electrolytes. Everything floods into the surrounding tissue. That's your third spacing, dropping the preload. And the body responds right. Sympathetic nervous system fires up, trying to compensate, maintain pressure.
And that ties back to the succinylcholine risk again with those receptors.
Precisely. Damaged muscle starts expressing those extrajunctional acetylcholine receptors, making it hypersensitive to succinylcholine's depolarizing effect, which can lead to a massive potassium efflux. Even before full-blown rhabdo is obvious, it's a known danger zone.
Okay, so moving into the operation itself, post-intubation, things were initially stable.
Seems like it, for a bit. But then, the moment the surgeon started, the debridement actually cleaning out the dead tissue things took a sharp turn.
What happened?
Blood pressure plummeted, down to 60 over 45 mmHg, and the heart rate jumped up to 100. Classic signs of shock, decompensation.
Okay, crisis point. This is where that advanced monitoring becomes crucial, right?
Absolutely. And now, with the patient intubated and ventilated, they could get that PPV measurement. And it was huge, 34%.
34%. Wow. So that confirms massive hypovolemia, doesn't it?
Unequivocally, a PPV over, say, 13% strongly suggests the patient needs volume. 34% is screaming, "I'm dry." They also managed to get an arterial line placed around this time right posterior tibial artery under ultrasound.
Posterior tibial makes sense, given the right arm injury.
Yeah, couldn't use the arm. And with that arterial line came the first blood gas result.
And the potassium,
Here.
given the earlier succinylcholine decision.
Potassium was 6.5 millibelow, definitely hyperkalemic.
Okay, so the risk became reality.
It did. And what made it even more concerning was a discrepancy. A serum sample sent right at induction, which finally came back around this time, showed a potassium of 4.5. Normal.
Huh. 4.5, then 6.5, very fickle.
So they immediately send another sample, specifically in a heparinized tube this time, to get an accurate arterial gas value again, and that came back even higher. 6.9 millimole.
Whoa! Okay, so a rapid, confirmed rise to nearly 7. Why such a fast jump? And why the discrepancy?
Well, several things are likely colliding here. First, the surgical debridement itself, manipulating and removing that dying muscle tissue, can literally squeeze potassium out of the damaged cells right into the bloodstream. Big bolus effect.
Huh. Okay.
Second, the heparinized sample is key for accuracy on a blood gas machine, minimizing artifactual changes that can happen in a plain serum tube over time, especially with potential hemolysis. But the trend here, confirmed by the heparinized sample, points to a true rapid in vivo increase.
Right. So back to molecular level again. What's driving this dramatic hyperkalemia now?
It's likely a double whammy. You've got the potential contribution from the succinylcholine acting on those upregulated extrajunctional receptors we talked about.
Yeah.
And on top of that, you have full-blown rhabdomyolysis kicking in from the extensive muscle breakdown.
Rhabdo releasing intracellular potassium.
Exactly. Tons of potassium, lactate, myoglobin, all spilling out from those dying muscle cells into the circulation. Just like Bosch and Weisberg describe in their work, it's a flood.
And how does the severe hypotension and that crazy high PPV fit into this picture?
Well, the volume loss from third spacing and potential bleeding directly causes the low preload, hence the low BP and high PPV. But also, the massive tissue injury triggers a systemic inflammatory response syndrome, SIRS,
Right, sirs.
which causes vasodilation, making the blood vessels leaky and floppy, further dropping the pressure and worsening fluid shifts. It's a vicious cycle. Injury leads to fluid loss and inflammation, which worsens perfusion and electrolyte chaos.
Okay, so the patient is crashing. Hypotensive, severely hyperkalemic. What's the plan? Aggressive resuscitation, I assume. Talk us through the fluids they gave. It looks like a lot.
It was. They threw the kitchen sink at it, basically. 5 units of packed red blood cells for oxygen carrying capacity and volume. 2 units of fresh frozen plasma for clotting factors and volume. 100 milliliters of 20% albumin, that's a colloid, helps pull fluid back into the vessels. 500 milliliters of gelifusine, another colloid. 500 milliliters of plasmolite initially.
Ah, plasmolite, a balanced solution.
Yes, but then they made a key switch. They stopped the plasmolite and gave 3.5 liters of normal saline.
Okay, why the switch specifically from plasmolite to normal saline? That seems deliberate.
Absolutely deliberate.
Hey.
And crucial, remember the hyperkalemia. Plasmolite and other balanced solutions contain potassium, usually around 5 millieql. In a patient whose potassium is already critically high, you want to avoid any extra potassium load. Normal saline is potassium-free.
Right, makes perfect sense. Minimize the K plus input.
Exactly. It was a smart, targeted choice in this specific context.
And did this massive fluid push work? What happened to the hemodynamics?
It worked significantly. The PPV dropped dramatically from that 34% all the way down to 12%.
12%, so back towards a more normal range.
Right. A huge improvement. Showed he was profoundly volume depleted initially, and the resuscitation was effectively restoring his circulating volume.
So physiologically, how do all these different fluids help? The colloids versus crystalloids, the blood products.
Okay, so the colloids, albumin, gelifusine, they work by increasing oncotic pressure inside the blood vessels. Think of them like protein magnets pulling fluid back in from the tissues, boosting intravascular volume. Normal saline is a crystalloid, It primarily expands the extracellular space, helps dilute the high potassium, and importantly supports kidney perfusion, which is vital for excreting potassium.
And the blood products.
PRBCs obviously replace lost red cells carrying oxygen. FFP provides clotting factors, crucial in trauma, and also adds volume. It's a combined strategy, like Myburr and Pearl's research supports using different tools to fix different parts of the problem.
Okay, fluids are going in, hemodynamics improving, but what about directly tackling that potassium level of 6.9? That needs specific treatment, right?
Absolutely. And they used a multi-pronged approach, hitting it from different angles based on standard hyperkalemia management. First, calcium gluconate 10 milliliters of 10%, given over 10 minutes.
And that's for cardiac protection.
Exactly. Doesn't lower the potassium level itself, but stabilizes the heart muscle cell membranes, makes them less likely to fibrillate from the high K plus lac. Buys you time.
Critical first step. What else?
Then the classic combo, insulin and dextrose.
Yeah.
10 units of regular insulin with 50 milliliters of 50% dextrose, D50. Insulin activates the sodium-potassium pump, driving potassium into the cells out of the bloodstream. Dextrose prevents the insulin from causing hypoglycemia.
Shifting the potassium intracellularly. Got it.
Right. They also gave sodium bicarbonate, 50 millidq IV. The notes say it was given if the pH was less than 7.2. Bicarb helps correct acidosis, and acidosis makes hyperkalemia worse. Correcting it helps shift potassium into cells too, exchanging for hydrogen ions.
Okay. And one more agent mentioned?
Yeah, nebulized salbutamol, 10 to 20 milligrams. That's a beta-2 agonist like asthma medication. Beta-2 activation also stimulates that same sodium-potassium pump, pushing more K plus intracellularly.
So multiple mechanisms all aimed at getting potassium out of the blood and into the cells, plus stabilizing the heart. What about diuretics like Lasix, often used for hyperkalemia? Weren't they used here?
Good question. The case explicitly notes they avoided loop diuretics. And the reason was the ongoing hypotension. Diuretics make you pee out fluid, which would worsen the low blood pressure they were still fighting.
Okay. Risk versus benefit again.
Precisely. Since the patient was making adequate urine, the thinking was likely that the kidneys would eventually help excrete the potassium once hemodynamics were stable, without needing the risky diuretic push right then. It aligns with guidelines like Stearns' treat the context, not just the number.
Makes sense. Now let's shift to the lungs. During all this resuscitation, the peak airway pressure went up. From 34 to 38 centimeter H2O, what does that tell us?
Yeah, that's an important observation. An increase in peak inspiratory pressure, or PIP, means it's getting harder to push air into the lungs. The lungs are becoming less compliant, stiffer.
And why would that happen in this scenario, with the crush injury and all the fluids?
Two main culprits, likely working together. First, all that fluid resuscitation, while necessary, can lead to some fluid leaking into the lung tissue itself. Pulmonary interstitial edema makes the lungs wet and heavy.
Okay, fluid overload in the lungs.
Sort of, or at least fluid shifting. Second, remember that systemic inflammatory response, SIRRs. Those inflammatory cytokines circulating can damage the tiny blood vessels in the lungs, making them leaky too. It's the beginning of what could become ARDS, acute respiratory distress syndrome.
So faced with stiffening lungs, how did they manage the ventilator? You don't want to cause more damage with high pressures.
Exactly. They used a lung protective strategy. Tidal volumes the size of each breath were kept moderate, around 6 to 8 milliliters per kilogram of ideal body weight. For this guy, that's about 420 to 560 millilords. Respiratory rate was kept physiological, 10 to 12 breaths per minute, and they used a relatively low level of PEEP, positive end expiratory pressure, just 5 centimeter H2O. PEEP helps keep the air sacs open, improving oxygenation without needing super high pressures.
So following ARDS network principles, basically.
Pretty much. Trying to support gas exchange while minimizing ventilator-induced lung injury, which, as texts like West explain, is a real risk when compliance drops and pressures rise.
Interesting. Now, another medication popped up, N-acetylcysteine, or NAC. Why was that given? Seems a bit different from the other immediate life support drugs.
It is a bit different. NAC was given IEV, 150 milligrams per kilo over an hour, so a pretty hefty dose, around 13.5 grams for him. The main reason here is antioxidant support, specifically hoping to prevent acute kidney injury, or ATN.
How does NAC help the kidneys in this situation? It's related to the rhabdomyolysis, right?
Exactly. Rhabdo releases myoglobin from the muscle. Myoglobin is toxic to the kidney tubules, especially in acidic urine. NAC is a precursor to glutathione, a major antioxidant in the body. So the theory is, boosting glutathione levels with NAC helps neutralize damaging free radicals produced by the muscle breakdown and myoglobin metabolism. There's also some thought, as studies like Teppels and Hunnens explore, that NAC might improve renal blood flow through vasodilation and reducing oxidative stress in the kidney itself. It's aimed at kidney protection during this high-risk period.
Got it. Okay, so they navigated the surgery, the resuscitation, the hyperkalemia. What happened immediately after the operation?
Given how unstable he'd been, the decision was made to keep him intubated and ventilated electively overnight in the ICU. Safer to keep a very close eye on him. Continue support as needed.
Makes sense. And how did he do over the next day or so?
Pretty well, actually. He was successfully extubated on postoperative day 1.
Good news.
Yeah. Follow-up tests like troponin and BNP, which check for heart strain, were normal. An echocardiogram of his heart was also normal, so no obvious major cardiac hit, despite the hyperkalemia.
That's great.
They continued to monitor for myoglobin in the urine using lab tests, not just relying on urine color, which isn't always accurate. The need for vasopressors like norepinephrine gradually decreased, down to a tiny dose, showing his circulation was stabilizing. And importantly, his kidneys kept working well. Urine output stayed consistently good, over 75 millinels per hour.
Excellent outcome on the renal front, especially after the rhabdo and potential NAC assist. You mentioned the long-term kidney risk from myoglobin pigment nephropathy. How is that managed post-op?
The key strategies, building on what we discussed, are continued aggressive IV hydration to keep fluids flushing through the kidneys, and often urine alkalinization, maybe with bicarbonate infusion, to make the urine less acidic. This helps prevent myoglobin from precipitating and clogging up the tubules. It's all about protecting those kidneys long-term. It's highlighted in classic work by Better and Melly.
Okay, one last area, regional anesthesia. For an arm injury like this, a nerve block seems logical for pain control, but they avoided it.
They did. Specifically, they avoided infraclavicular and intercostobrachial blocks, and there were solid reasons.
Such as?
2 main concerns. 1, the state of the limb. With significant tissue damage, potential infection, maybe borderline blood supply, a dense nerve block could mask the symptoms of compartment syndrome.
Ah, right. Numbness, pain changes wouldn't be felt. Critical delay in diagnosis.
Exactly. Compartment syndrome is a surgical emergency. You need to catch it fast.
Yeah.
2, the patient had SIRS, that's systemic inflammation. Performing a block in that setting carries a higher risk of introducing infection at the needle site. Plus, the block might not even work as reliably.
So the risks outweighed the potential benefits in this specific trauma case.
Correct. So they relied on general anesthesia during the case, and then likely a multimodal approach with IV pain meds afterwards, rather than a regional block.
This case is just packed with learning points. Can we try and summarize the big take-home messages for everyone listening?
Yeah, definitely. Let's boil it down. First, PPV positive pressure variation. Remember it as a dynamic guide for fluid status on the ventilator. Over 13%. Think volume needed. Under 10%. Probably okay volume-wise.
Got it. PPV for volume.
Second, saccinocholine and crush injuries, be extremely cautious, especially if the injury is older than 24 hours. This case showed hyperkalemia can happen even earlier, so weigh that risk carefully against the need for RSI.
Self-just caution, Jeff.
Third, hyperkalemia management is a 3-step process. 1, stabilize the heart, calcium. 2, shift K+ into cells, insulin dextrose, maybe salbutamol, bicarb if acidotic. 4th, rhabdomyolysis monitoring, support kidney function with fluids, diuretics only if hemodynamically stable.
Stabilize, shift, remove. Okay.
4th, rhabdomyolysis monitoring. Don't just trust urine color. Use lab test CK myoglobin for accurate diagnosis and tracking.
Labs over color for rhabdo.
Right. 5th, N-acetylcysteine, NAC, consider it as a potential kidney protector in the ICU for patients with significant rhabdomyolysis.
NSE for kidney support.
6th, high peak inspiratory pressure, PIP. On the vent, that's a warning sign. Could be stiff lungs from fluid, inflammation, maybe early ARDS. Investigate and adjust vent settings protectively.
High PIP equals warning.
7th, arterial line access. If the arms aren't usable, remember the posterior tibial artery is a viable option.
Alt access, posterior tib.
8th, planned overnight ventilation post-op can be a smart move for really unstable patients with SIRS. Allows for continued support and monitoring.
Elective ventilation for stability.
And finally, 9th, brachial plexus blocks. Be wary in limbs with infection, ischemia, or if the patient has SIRS. Risk of masking compartment syndrome or causing infection might be too high.
Regional caution in trauma SIRS. Wow, that's a lot of crucial insights from one case. Yeah, this deep dive really hammered home the challenges of a major crush injury, especially that rapid onset hyperkalemia and the cascade of problems it triggers. It just shows how vital understanding the underlying physiology is for making those critical moment-to-moment decisions.
Absolutely. And these principles, they're not just for anesthesiologists or intensivists. Anyone interested in emergency medicine, trauma care, or just how the body reacts under extreme stress can learn a lot here. The real aha moments are seeing how fluid balance, electrolytes, inflammation, they're all interconnected.
So here's a final thought for you to chew on. With point-of-care testing getting faster and more common, imagine getting a reliable potassium level right at the roadside or instantly in the ED. How might that change the very first steps in managing a crush injury like this? Would that succinylcholine decision be different?
That's a fascinating question. And relatedly, the debate around NAC continues. When exactly is the best time to give it? What's the ideal dose? Which patients benefit most? There's still research happening there.
Definitely things to explore further. We encourage you to look into the references if you want to dig deeper. Thanks so much for joining us on this deep dive. We hope thinking through these complexities has been valuable. And remember, look for the full Ink and Air channel launch on optimalanesthesia.com in June 2025 for more evidence-based content.
Until next time, keep questioning, keep learning. That deeper understanding is what makes the difference.